Good afternoon, everybody. Thank you very much for this invitation. I'll just, yeah, okay. So I'm just going to talk about our experience in Singapore and the establishment of an integrated pathway for stroke spasticity. So I have no potential conflicts. What we're going to cover today is an evidence-based approach to the design and development of a pathway. We use the narrative synthesis of post-stroke spasticity, and we redefine post-stroke spasticity care in a comprehensive and integrated fashion. And we developed criteria for surgical intervention, and we did a preliminary evaluation of our outcomes and our early experience with the use of this new pathway. And we'll talk a little bit about what's the further areas of development. As I declare my non-interest, I would urge you and the attendees for the next 10 minutes, just put aside your views and opinions about what you have practiced in post-stroke spasticity. I think this is a tremendously under investigated area, and we have failed to look at the psychosocial impact of spasticity. So I'm going to share with you some of the thoughts and ideas which don't come from mainstream stroke literature, but in other areas of cognitive neuroscience, psychology, and engineering. So we are all familiar with the problems of strokes in terms of the spasticity in post-stroke. So we exclude those without spasticity. There's been a lot of emphasis on the biophysical aspects of spasticity and very little on the psychosocial aspects of spasticity. So we'll look at that, and we'll touch a bit on that. So we used the DDR model, which is a design and developmental research model for identifying a problem and then getting the experts and getting the evidence for it, designing solutions and building a prototype, and then trying that out, evaluate, redesign, and pilot. So we've currently rolled out our integrated pathway in Singapore. So traditionally, we found that the patient post-stroke spasticity usually were harbored around the neurologist who managed them and the stroke physician, followed by mainly the rehab physician and therapist. And the surgeon gets involved very rarely. And in the 3 decades that I've been practicing as a hand surgeon, we usually end up seeing the patients who's got the contractures, even later than that, with the fingers digging into the palm. And I had a patient in the NHS who had dug so much into the hand that the thumb had fused with the index finger, and we had to amputate the finger. So that's kind of late, and that's not satisfactory. So we were looking forward to see a much more multidisciplinary team approach with the patient in the center. So we're looking at stroke physician and neurologists, rehab physicians, specialty nurses, therapists, and the surgeon being involved as part of the team even early to provide some form of care to the patient, and also to start the conversation going and building the team approach with the patient and the role of surgery to help with the patient's functions. So what we did was as part of the team, I left the names there because we've got 10 minutes. There's a big team. We had neurologists on our team. We had rehab physicians. We had occupational therapists, physiotherapists, hand surgeons. We had a resident. We had a couple of medical students help us out in designing this pathway. So we looked at the evidence, we looked at some literature review and the role of neurectomy. So neurectomy's role is to reduce spasticity. Spasticity arises from the loss of inhibition of the upper motor neuron and the lower motor neuron. So most of the hand surgeons are very familiar with lower motor neuron lesion, and that's where the understanding of, and the concept of spasticity is sometimes lost. So this was this review. It works. There is a recurrence rate. You got to cut the branches to the nerve, not the main nerve. We'll look at some of the other evidence for this. So this was a systematic review by Wheelam and group. And this is the terms that we use. So what's happening is when you inject Botox into the muscles, you're trying to paralyze the motor end plate. Whereas what we do in neurectomy is to take the branches of it, and in principle, you want to take out about 75 to 80% of the axons that goes into that particular muscle that is providing the problem. You must understand that there's an interconnectedness of the neurons within the spinal cord and in the brain. So increase in spasticity and increase in the gamma reflex that returns back also dissipates to the other motor neurons, producing problems in other segments of the motor unit. So one of the landmark papers that came out from Shanghai, China, was in 2018 in the use of a contralateral C7 nerve root from the brachial plexus to the C7 of the affected limb. Now, we use this in brachial plexus reanimation for paralyzed upper limb, and we have commonly used it. I've used it from the opposite C7 and put it into the C7 or the median nerve of the affected limb. So we've seen these connections happening in the brain, and this was done in a level 1 study, RCT, and they had shown that there was an increase in function as compared to just rehabilitation alone. There's a reduction in spasticity, and there were proof of physical connection, physiological connection between the ipsilateral cerebral hemisphere and the paralyzed hand. However, here's where people who are blinkered. On the same journal, the same volume, obviously they had insight. This group of authors who are basically lower motor neuron surgeons. Yes, so here was on the same journal, a rebuttal or a commentary by chosen authors who are basically peripheral nerve surgeons whom I know, and they were lower motor neurons. So they contradicted some of the, they're saying they were difficult to explain the results of the Shanghai study. And I put them there, I won't go into details. By cutting the C7 on the affected limb, you do a very proximal neurectomy and you reduce the spasticity in the whole limb. And they said that probably was the main cause of the outcomes that being better. But when there were connections occurring in the ipsilateral cortex, indicating that there were connections between the C7. So because of not understanding what's happening in the cognitive neuroscience area, research is happening, which most surgeons don't read. So that's where the failure to understand what happens. I think it's a very exciting work from Shanghai. There have been people who have gone from the US to validate the results of the Shanghai group. So we await for further studies. Now, to understand a grasp action in the upper limb especially, so you need to understand human volition. So here's where, if you start reading, you need to look at the generativity, the subjectivity, and the teleology of how a particular task is being performed before we can understand in managing this. So it's just not having one group of muscles reducing the tone, but overall objective for producing volition. I think that's important. And again, to understand that what happens in stroke spasticity is there's the concept of spontaneous recovery, which is von Monacau's diastasis reversal, which is the axonal shock from the immediate effect of the injury, be it a hemorrhage or is it a thrombus, and the reversal of that, which is what we call the restoration of function. Then there is the cortical reorganization, which is both can be chemical in nature and structural in nature, and then the plasticity, the neuroplasticity that comes out. So I think this is an important thing to remember. And the other thing that you must also understand, what does spasticity produce centrally to the patient? So what happens to the patient is he has requires more energy, more cognitive load, both intrinsic, extrinsic, and germane cognitive load to rehabilitate himself. So the reduction of the spasticity reduces the load. And so the energy required is reduced. So that's an area which nobody's measuring in the outcomes. Secondly, that you will find that back to Pavlovian concept of conditioning, if I don't get the reward of grasping an object because it's too difficult, the patient has no motivation to continue the rehabilitation. So they will then look for alternative and use the opposite limb. So this is an important concept to understand. The other thing about neuroplasticity that you must understand is the concept of Hebbian learning, that repeated attempts at and persistent stimulation of the synapses results in structural changes with the production of new dendrites and synapses, making learning occurring in the rehabilitation phase. So this is, again, important concept to remember. Goran Lundberg talked about, especially in lower motor neuron, this is just diagrammatic explanation of how spasticity occurred with the increase in dendrites, is the black hole that is created when you have a paralysis as a result of a stroke, which is then encroached upon by the homunculus of the other areas nearby. And this is seen in sensory parts in lower motor neuron, and I think there's a role to play in upper motor neuron. So we got this whole evidence that we read from all the literature, outside that of stroke literature and outside that of hand surgery, and we found that there is an evidence to try and bring about surgery incorporating it into the pathway. I want to make it very clear that surgery is not the end all. We play a very small part, but I think we need to choose those patients to be able to provide some form of improvement in the patient's overall experience following stroke spasticity. So this is our pathway that we have. So we work very closely with our stroke physicians, who then refer to the stroke hand clinic, which is manned by our rehabilitation colleagues, stroke physician, and the hand surgeon with an advanced care practitioner in stroke nursing. And those who are general spasticity are managed by the rehab physicians and the stroke physicians. We look at regional and focal spasticity, and we decide between contracture and spasticity. So if there's contracture, then these are standard procedures that's already been available. These are what I call neglected spasticity. And then we look at those that have got, whether they have volitional control. Obviously, if there's no volitional control, then there's very little that we can do from surgical intervention. We will continue with the rehabilitation. But if there's no volitional control, if there is volitional control, then we will do a trial of Botox injection to see whether they have improvement. And we ask the patient whether that really made a difference in his life, and would he like to have that a little bit more permanent than just the temporary effects of Botox. And if they kind of feel that, then we consider selective neurotomy. So here we have the various non-surgical and surgical. I won't spend too much. So this is these are our aims. We're trying to improve function, reduce pain, improve posture and care, and also self-esteem. And I think that's important. So we look at both upper limb and lower limb from spasticity. We not only look at those with stroke, we also manage those with brain and spinal cord injuries, and some with focal dystonia from psychiatric medication. And inclusion criteria, these are very standard inclusion. So those that have volition, that have a good prognosis for recovery, and who are willing to undergo our prolonged period of rehabilitation and being involved in the care. The exclusion criteria, any bedbound patients who are unable to communicate, we really can't. We sometimes will do certain procedures for hand hygiene. So this is our experience. We've had about 22 patients, 17 of which were stroke. Like I said, we have a couple of cerebral palsy, which is a different cohort altogether. We do have focal dystonia from psychiatric medication, which can be quite serious. So we've done a couple with some pretty impressive results. And so these are the types of nerves that we have done, selective, hyper-selective neurectomies. So here's an example of somebody with had a lot of biceps spasticity, yet pretty good volition. But every time she tries here with the gravity effect helping her with the flexion, she's good. But post neurectomy, you can see the scar in the biceps. She has a better control and a fuller range of movement, for which she is quite pleased in terms of the results. Here, I'll just show you flexor carpi ulnaris neurectomy, how they perform. So all these are done. These are very small procedures. They're not very long, done usually under regional anesthesia. We find the branch of the nerve to the flexor carpi ulnaris. We stimulate it on the table. until we get contractions. We confirm that that is the branch that going to that muscle, which already determined pre-op, and then we just excise at least a 1 centimeter segment of the nerve so as to prevent axonal regeneration and reinnervation. So this reduces the motor input into the flexor carpi ulnaris. There's usually another branch a bit more distally. So we don't remove all, we take up about 80% of the axons to the muscle. Here a couple of more examples. So this is the flexor carpi radialis neurectomy. And here we stimulate the nerve with the stimulator. So we dissect, we find the branches, and it's a highly selective neurectomy. If there's only a single branch, if you find there's only a single branch to that muscle, then we do a partial neurectomy. We cut out a segment, but leaving a fascicle intact, at least 20%, to provide some action there. So here's just a diagrammatic. This is for flexor digitorum sublimis. And here again, this is the flexor pollicis longus. So you can see the stimulation in the flexor pollicis longus. FPL may have only a single branch, then we will only do a 80%. And I think this is the improvement in the spasticity immediately post-op. Here's the lower limb. This patient had obviously the classical features of spasticity in the lower limb, with the flexor digitorum longus and the flexor hallucis longus was in spasm, as you can see very clearly in the static image. So here we provide the stimulation and do a neurectomy in both the FHL and the FDL. And you see in the post-op that he has got a better gait. And if you try and measure this, you will find that there's not very much improvement. A Fergal-Mayer score may not be great. But if you ask the patient's really, really pleased, because now they can walk barefoot in the house, they feel better, more comfortable, they are less pain because the spasticity is gone. And you can see here, the FHL is reduced flexion in the IPJ, and the FDLs are less flex. So generally, these are early results. We're still following post-COVID. We didn't run this specialized clinic, so we hope next month we're starting it again, and we'll add to it. These are, like I said, it's early days. We've been quite pleased with the improvement in the spasticity scores post-op. In terms of patient satisfaction, we have a mixed bag. We had a couple of patients who had some not so good experience post-op because of the anesthesia complication. And so, but you look at one of the patients who did better in the lower limb than in the upper limb. So he had a lot of high expectations. These are very patients who have got quite a bit of expectations. They need to be managed adequately. So the take-home message is the management strategies are evolving. I think looking at it, I think the assessment instruments needs to be modified. We're using instruments that are quite aged. They are very biophysical in nature. Nobody's measuring patient-reported experience measures, and I think that is important, and incorporating cognitive load into the instruments of measurement. There need to be more interactions among the MDT involved, the multidisciplinary team involved in stroke management. Get your hand surgeons involved. We need to counsel not just patients, we need to counsel the family, we need to counsel our colleagues in the MDT. That's what I feel. And educating and raising awareness. And I recently presented this early January in Erasmus Medical Center, and they are now very keen to start a stroke hand clinic in Erasmus. And I think this is something. What's the future? I think we need to develop and design new instruments incorporating cognitive load. So any of your therapists out there or psychologists, let's start looking at something more. Let's start measuring psychosocial impacts in stroke spasticity. And I think there's going to be a big area of improvement in the management with contralateral C7 transfers. Thank you.